Yeah, welcome all. Good evening to my dear friends and colleagues from India, and good morning from the audiences from US. So today I will be speaking on musculoskeletal PET-CT applications. So PET-CT, as everyone knows, it is one of the most important, fascinating uh, modality which has developed. It is a molecular imaging modality. Biochemical changes at a tissue level can be seen very clearly with the PET, and earliest metabolic changes in the musculoskeletal disorders. So coming to imaging, how does the PET has an impact on the imaging of musculoskeletal system or disorders? It has become an integral part of the evaluation of the musculoskeletal disorders for the diagnosis, for the management. Primarily, conventional methods like plain film radiography, CT, or MR, which provides high resolution structural information. But functional and molecular information is not provided by all these conventional modalities. So, here comes the role of a PET, which can play an important role and gives information in relation to the tissues and disease characterization, and this is provided by the PET imaging technique, and there is a distribution and uptake of positron emitting radio tracers. So just before starting the cases and showing how exactly the musculoskeletal system is being uh, impacted by the PET-CT, I just want to give a brief overview how the radiochemistry and radiopharmaceuticals forms the base of the imaging in the PET. So PET radiochemistry, where 18 fluorine is a radioisotope and it is a backbone for the PET imaging, and it is produced in a cyclotron. So nuclear reaction between the oxygen 18 enriched water bombarded with protons, releasing a neutron with the production equations forming the 18 fluorine. Two most commonly used radio tracers for PET imaging of musculoskeletal disorders are F18 fluorodeoxyglucose. So it uses the glucose metabolism, sensitive for acute phase cellular response, inflammation and infection. And the another most important use is 18 fluorine sodium fluoride, that is for finding the bone remodeling. It is like a bone scan, not our routine nuclear MDP bone scan, but it is different. It is a PET bone scan, what we call in another way. But most commonly used is 18 fluorine deoxyglucose, that is FDG. So coming to PET in MSK, the major indications are oncological indications where PET alone can be used, PET CT or PET MR imaging, which is a new modality with lot of expectations from gray areas which are not answered in PET and PET CT, because MR is very highly sensitive for the soft tissue imaging. And here it maximizes the strength of both imaging approaches, and the most common indications are primary tumors and secondary metastatic tumors involving musculoskeletal system. Coming to other applications are infections, musculoskeletal infections, diabetic foot probably involving the different muscles and the musculoskeletal structures, bones, painful arthroplasties, metabolic bone diseases, then evaluation of a back pain. This is something a very new fascinating concept which has come. Patient presenting with back pain, evaluation by the PET. We know so many things are happening, especially related with the joints, arthritis, or any infection, inflammation, or any tumors. Coming to non-malignant bone marrow disorders, arthritis, benign non-malignant conditions of musculoskeletal system, bone graft viability, healing fractures, and osteonecrosis. So PET is more sensitive and specific for early detection and characterization of musculoskeletal disorders, and it is limited by its relatively low spatial resolution. This is one of the important drawback which is there with the PET. So 18F FDG PET CT is dedicated in musculoskeletal disorders, having a potential imaging modality, especially high grade malignancies and benign tumors, low and high grade malignant tumors, and the quantification is done by mean standardized uptake value, that is SUV values. So with this, we can go to evaluate or to stage the oncological responses, evaluating the response to therapy in musculoskeletal tumors, improving patient management. So FDG is not a specific marker for malignant musculoskeletal lesions, and false positive FDG PET findings are there. So coming to this table, which shows various false positive and false negative FDG PET results in various musculoskeletal lesions, there is a big list actually. It may be wondering how come the FDG PET is being used. So if you see the primary site of soft tissue lesions, there are blend of pathologies like you have pigmented villonodular synovitis, hibernoma, sarcoidosis, myositis ossificans, non-ossifying fibroma, neurofibroma, schwannoma, distal fibromatosis, abscess, inflammatory conditions. So it has a very high uptake in these benign lesions. But there are a couple of low grade uptake in reverse malignant lesions like you have myxoid liposarcomas, well differentiated liposarcomas, low grade fibromyxoid sarcomas and spindle cell tumors. These are in relation with the soft tissue lesions. Now coming to bony lesions, still couple of bony benign lesions like osteoid osteoma, histiocytosis X, chondroblastoma, enchondroma, giant cell tumors, and fibrous dysplasias will have high uptake. And on contrary, chondrosarcoma and chordoma can have a less uptake even though they are malignant lesions. So couple of these pathologies which I will be showing in coming slides. So coming to the important aspect, FDG and non-FDG tracers in musculoskeletal lesions. So there are different radio tracers available, but as I told you, the FDG is the most common used because of the glucose metabolism. It is widely available and it is most commonly used radio tracer. So most applications are staging and grading of musculoskeletal tumors to differentiate between benign and malignant musculoskeletal lesions, therapeutic response assessment in musculoskeletal tumors, and guided biopsy from lesions. Another one, already I told, it is a sodium fluoride, where bone imaging agent fluoride ion exchange for a hydroxyl group in the bone crystal and forms fluoroapatite. This deposits at the bone surface where turnover is greatest. However, detection of bone metastasis in oncological cases, assessment of benign bone pathology like low back pain. So this is one of the ideal radio tracer for the evaluation of a back pain. Now there are a couple of things which are coming other than this FDG and sodium fluoride are FLT and FET and FMT. So they have certain advantages, especially in relation where the FDG is not much of relevance and has some sort of a gray areas where there is a overlap and cannot differentiate between benign and the malignant tumors and the viable and non-viable tumors. And so these are the new radio tracers, not widely available, but still like in future probably they will be one of the adjunct to FDG and sodium fluoride. These are other things still galacto-RDG and fluoroethylcholine. Then 11C based radiopharmaceuticals are 11C methionine and 11C choline. These are already available, but they are not so widely used, especially for the musculoskeletal lesions. And this is PSMA and Dotanoc. They are widely used for their specific, like prostate cancers, PSMA is used, and NET, neuroendocrine tumors, Dotatate and Dotanoc is used. So obviously whenever there is a staging evaluation or any sort of oncological setup evaluation, definitely the bone lesions are picked up and they are quite sensitive with these both forms of radio tracers. Now coming to few clinical factors affecting the FDG biodistribution. They are considered and possibly avoided by delaying the FDG PET during the active processes. And important timelines to be followed. They are inflammatory or infectious process, radiation therapy, that is interval between therapy and FDG PET recommended is at least around 6 to 12 weeks. Recent surgery, interval between therapy and FDG PET is around 4 weeks. Recent chemotherapy, interval therapy between the treatment and FDG PET is 2 to 4 weeks. And sometimes cytokines or growth factor therapy, interval between therapy and FDG PET scan is 3 to 4 weeks. And increased FDG uptake in the bone marrow and that factors are important in the evaluation of musculoskeletal lesions. So these are very, very important because post radiation, post surgery, post chemotherapy or growth factor therapies. So this sort of things, like for example, post radiation, probably there can be radiation inflammation. So if you are doing a PET within this time interval which is less than this, then probably the inflammation because of radiation can also give false results and give a false uptake. Same happens with the surgery, because post surgical inflammation is there, so it will become very difficult to distinguish between the original lesion or primary lesion versus the post surgical inflammation, which also will have an uptake significantly. So it is not advisable to do the PET immediately within 4 weeks of surgery. And chemotherapy also, there can be post chemotherapy changes which can be giving false results, and same applies to the growth factor therapies. Coming to hyperglycemic states, FDG uptake in the tumor is reduced. Blood glucose level should be checked. This is very important before administering the FDG, because musculoskeletal lesions, if there is increased blood glucose level, it is a problematic, and increased insulin levels, FDG biodistribution, then shifting its uptake to muscle and fat. So difficulty in interpreting musculoskeletal lesions. And the ideal blood sugar level should be 130 to 150 milligram per deciliter in non-diabetic patients, 180 to 200 milligram per deciliter in diabetic patients, and thus it will have no impact or alteration in the FDG biodistribution. So coming to certain facts, 24 hours before FDG study, all patients are advised to refrain from any strenuous activity or exercise, because any sort of physiological muscle uptake should be minimized, and this, if there is present, then probably it will be difficult for the evaluation of musculoskeletal pathologies. If needed, benzodiazepines 5 milligram may be administered 60 minutes before FDG injection, and to obtain higher muscle relaxation, less physiologic FDG uptake in the muscles, and anxious patients, and higher FDG uptake in trapezius and paraspinal muscles. So after FDG injection, patient must be seated or recumbent in a comfortable chair or bed to prevent or reduce brown fat FDG uptake. This is also important. And use of warming and low dose beta blockers to minimize the brown fat uptake, which is one of the important false uh, uptake which will be seeing and competing with the muscle uptake, and this is seen especially in a cold weather and predominantly in head and neck regions. And propranolol 20 milligrams 60 minutes before the FDG injection can also be given, and this is important for the evaluation of musculoskeletal disorders. So coming to dose of FDG, 185 to 555 millibecquerel, that is 5 to 14 millicurie for adults. It depends again on a age of a on the weight of a patient. And for pediatric age group, it is 0.10 to 0.14 millicurie per kg for pediatric age group, and both has to be kept along with the ALARA principle as low as reasonably achievable, because by injecting more you have to have a optimal study both the things. So you should not inject more, and the study also should be very proper and optimal. So you have to follow the principle of ALARA. And protocol is developed with consideration of patient related factors like age, weight, bone body mass. Scanner related factors are there technically, depending on the crystals which are used in the PET, that are known as scintillators. Then acquisition mode, whether it is 2D, 3D or bed overlap is there. Then acquisition time per bed position. This is very important. Now FDG injection ideally should be given in contralateral arm to a primary tumor in the thorax, breast or arm. Furosemide injections, dose from 2 milligram per kg to 40 milligram, evaluating pelvic lesions to increase urinary clearance from bladder and less interference from high FDG activity in the urine. So FDG is a glucose analog transported into cells by membrane glucose transporters. It is trapped intracellularly and phosphorylated by hexokinase into FDG6 phosphate. So there are a couple of parameters for the PET scan acquisition. Briefly, I am not going in detail, but just this is for the uh, factors technically which are to be maintained. And this is important. Variant of CT protocol. There are a couple of protocols where we use low dose CT without IV contrast. and diagnostic CT protocol with use of IV and oral contrast. So both of them, they are having advantages and disadvantages. But preferably, if you are using IV contrast and oral contrast, you are doing a proper CT study. And in our institutes, we use this protocol of giving IV and proper oral contrast so that we give a proper CT related complete information along with the PET. But still, there may be some sort of errors, especially in relation with the contrast related artifacts and the errors in SUV measurements. And the other important aspect is the more exposure, radiation exposure dose. So oncology imaging mostly is PET CT, PET MR imaging, but FDG whole body imaging is the commonest and most widely followed protocol, that is from the vertex of skull to mid thigh, and limited imaging, that is joint prosthesis, is one of the example where we do the limited musculoskeletal imaging. So again, this is in relation with the patient site and the protocols, whole body imaging, site, upper, lower limbs and multiple regions. So if needed, upper and lower limbs has to be done separately along with the whole body protocol, especially in cases of osteosarcoma, rhabdomyosarcoma and liposarcoma. And limited areas where you are evaluating backache, joint cell, benign tumors or benign lesions like osteoid, osteoma. And skull base to mid proximal thigh, again same conditions where lymphoma, chordoma, head and neck, melanoma. But especially melanomas, you have to do the both lower limbs also, because we don't know where the lesion is, and melanoma is one of the most notorious malignancy involving the cutaneous and subcutaneous planes in the extremities. This is different protocols. Just for information, I am showing malignant musculoskeletal tumors. And you have sarcomas, Ewing sarcoma, chordoma, chondrosarcoma, rhabdomyosarcomas, liposarcomas, leiomyosarcomas, and malignant peripheral nerve sheath tumors. So these are the malignant lesions, and depending on the site, most of them, the PET coverage is whole body. All of them are whole body, and the CT protocol is most of them. Here what has been mentioned is diagnostic CT without oral and IV, but still in our center it is advisable and we do follow the proper protocol of giving oral contrast as well as IV contrast. And this is again with the benign, most of the times it is a limited region imaging. If you see the osteoid, osteoma, intraosseous hemangioma, enchondromas and enchondromatosis, giant cell tumors and osteomyelitis. So most of the sites are based on the limbs, vertebra, small bones and long bones. But here most of the things like osteoid, osteoma is limited area imaging, and enchondromas, it can be whole body or limited. Hemangiomas also same, but joint cell and osteomyelitis is more focus. Again, it depends on case to case variation and the involvement and clinical symptoms. Now, before showing the cases, how is the uptake in the PET being quantified? So it is based by the SUV max values, that is standardized uptake values, max values. So this is for the quantification of uptake, and different theories and values are there, but most widely used is less than 2 is most likely benign, 2 to 4 is borderline, it can be low grade tumors, low grade infections. 4 and above is consistently with a high grade activity of malignant tumors. But here, active inflammation, active infection like tuberculosis, or any sort of osteomyelitis, or any sort of infection, high grade infection will also show. Now, how you are going to differentiate between the malignant lesions versus infective inflammatory pathologies, which will both of them will have an high uptake? And the concept is dual point imaging. What exactly is a dual point imaging? It is a delayed PET imaging after a proper PET whole body, probably after 1 hour, 2 hours, 3 hours, or 4 hours, depending on the case, depending on the clinical symptoms and the area of interest, it can be done. But here the concept is, if you are doing a delayed scan after 1 hour, then probably whatever SUV values you have got after a proper PET, then in delayed scan, if the SUV values are same or increasing, then probably it goes more in a favor of malignant lesions, because the concept here is malignant tumors or malignant cells will have a capacity to retain the tracer uptake within the cells. On contrary, if the SU value is falling down in the delayed scan, then it goes more in a favor of infective inflammatory pathology because they are not having as capable as malignant cells to retain the tracer contrast. So, with this, the dual point imaging helps, but it is still not 100%. Lot of literatures are available which says around 80%, 90% or sometimes 90% of cases they can be distinguishing between malignant and infective inflammatory pathologies, but not 100%. So, coming to the back to the important musculoskeletal tumors, you have you have skeletal. So, there are soft tissue tumors and bony tumors. So, malignancy in soft tissue tumors is rare, that is 0.7% of adult and 7% of childhood malignancies. Soft tissue tumors are anywhere in the body, commonly involve the extremities and intra-abdominal regions. Tumors may originate from fatty tissues like lipoma, liposarcoma, muscles like myoma, leiomyosarcoma, and rhabdomyosarcoma, connective tissues like fibroma, fibrosarcoma, blood vessels, angioma, hemangioma, and angiosarcoma, neurogenic tissue, schwannomas, malignant peripheral nerve sheath tumors, and malignant schwannomas. These are the soft tissue tumors. Now, coming to bony, you have Ewing sarcoma, osteosarcomas, chondrosarcomas. These are the common malignant lesions that arise from extremities, mostly from the lower limbs. Now, several studies showed a positive correlation between FDG uptake and the histopathological grade of musculoskeletal tumors. So, it means FDG uptake directly proportional to the grade of a tumor. So, more the uptake, high grade the tumor, less the uptake, lesser the grade of a tumor. So, PET may help to ensure accurate grading and prognostication in sarcomas by guiding the biopsy to the most biologically significant region. And as shown by Folpe and colleagues, 34 with a positive correlation between the SUV and histopathological grade. So, now coming to the cases, I will be showing blend of variety of cases where the application of PET is there in the musculoskeletal system. So, this was a 18 years old female diagnosed primary Ewing sarcoma for staging. So, if you see, this is a local infiltrative lesion here which is involving the entire group of the thigh muscles here, but rest of the whole body is normal. This is a urinary bladder uptake which is normal. And if you see this, this is only the local disease here infiltrating the vessel, abutting the vessels here, but involving the muscles in the anterior and anteromedial compartment of the proximal thigh. So, this is for the quantification. We can maintain how infiltrating the lesion is. And if you see the center of a lesion, it is a necrotic here, and that necrosis or cystic areas will not show an uptake in the FDG or any radiotracer used. 27 years old with left upper leg pain with suspicion of primary bone lesion, referred for PET. It was osteochondroma, which shows SU max of 2.8. If you see this, this is lobulated osseous lesion here, which is like some sort of bulging here with the rest of the bones are absolutely normal, no significant uptake except minimal, which is having roughly the value of 2.8. So, it is consistent with the benign lesion entity. Same lesion in the coronal planes here, see it is lobulated, so minimal uptake, minimal uptake. It is a bony lesion, rest of the bones and soft tissues are perfectly normal. This is 42 years old with 3 months history of fracture. So, non-healing with soft tissue swelling and discharge, post-traumatic sequelae. So, this is a fracture here which is like some sort of non-healing, and there is associated subtle soft tissue in the marrow of the tibia as well as some sort of a periosteal reaction which is seen here. And again it is involving in the region of a foot. So, it was consistent with the uptake, and this uptake is most probably likely because of the osteomyelitis. So, lot of literature is available which shows the application in the osteomyelitis. This is 39 years old with non-healing ulcer, PET CT focal area of high uptake. Histopathology was cutaneous squamous cell carcinoma. This is that, and uptake wise it is very difficult actually. It can be some sort of a infection even diabetic foot, even there is a basal cell carcinoma, melanoma, or simply because of DVT or any sort of significant Raynaud's disease or arteriosclerosis. These are the findings which are the differentials for this, but histopathology concurrent with cutaneous. And this is a lower limb PET because the height of the patient, adult patient, does not fit completely in the PET table. So you have to do the whole body from base of skull or vertex of skull to the thigh, mid thigh. Then the rest of the lower limb has to be done separately. So rest of the body was absolutely normal. It is only the focal area, and it is a primary cutaneous squamous cell carcinoma. Coming to 45 years old with pain, base of thumb gradually increasing, PET CT showing erosion with a very high uptake, standardized uptake max value was 20, and histopathologically it was malignant fibrous histiocytoma. So this is a lesion with the erosion of the bone here and with associated soft tissue component. But here you cannot delineate here, and it is showing significant high amount of uptake in the region of base of a thumb. So the metacarpal of the thumb is involved, and this is a destructive lesion involving bone as well as surrounding soft tissues. So coming to 48 years old with diagnosed osteosarcoma, PET CT for staging. It is a classical osteosarcoma. Here is a periostal reaction here, speculated here, with infiltration into the adjacent soft tissues. And if you see the marrow is having, again there is a thickening of the cortex, irregularity of the cortex, and there is a patchily enhancing soft tissue component within the medullary cavity. So you have extraosseous soft tissue component and intramedullary with cortical thickening, periostal reaction. So it is a classical of osteosarcoma. So these are the axial sections and these are the sagittal sections. So coming to 40 years old with expansile lesion with cortical fractures, lower shaft of tibia. So it was supposed to be diagnosed tentatively as giant cell tumor, and PET CT was advised to rule out malignancy. So it is diagnosed GCT probably, and to rule out any malignancy or malignant transformation. So if you see, it is a expansile, then there is a cortical irregularity with erosions and breaks, and there is associated soft tissue component within this with minimal or no negligible uptake. So it was consistent with the benign entity. Now coming to 50 years old with diabetic foot. So what exactly has a diabetic foot in relation with the muscles? Because diabetic foot will involve cutaneous planes, subcutaneous planes, muscles, bones. So usually if it is involving the bones, osteopenia is there is erosion, fracture, autoimputation. So many processes which happens in the diabetic foot. So here you have extensive subcutaneous edema with the skin thickening, then the subcutaneous fat plane is completely infiltrated, intermuscular planes are not clearly defined. But here these are the all soft tissue components which are showing significant uptake involving the muscle, skin and the subcutaneous planes on either sides around the ankle. So this is consistent with the diabetic foot. So diabetic foot, what are all the things? Complications. It can lead to osteomyelitis, Charcot's neuroarthropathy, and in the diabetic patients. So this was a 58 years old with extensive large chondrosarcoma. PET CT for whole body staging shows extensive disease. So it is a large, huge mass which is involving the right hemipelvis, displacing the structures on other side and infiltrating all the structures with bony erosion, destruction, neovascularization. Multiple necrotic areas are there, extending to involve the hip joint and the neck of the femur, and this significant displacement of the structures on the opposite side. So it was consistent with the extensive disease. So this was the same case which has extensive skeletal, liver, mediastinal and nodal metastasis along with the primary chondrosarcoma. So it was extensive disease involving the chondrosarcoma. Now coming to recurrent osteosarcoma postoperative. Usually postoperatively once it is done, then probably again recurrence rate is there, and the role of other imaging modalities, like if you see the CT, very difficult to see the what is happening because of the artifact, metal streaky artifacts are seen. But the PET helps in this because MR will not be useful because of the metallic implants or metallic structures. You can't do MRI. So the only remaining modality and the best modality is the PET. So here, if you see, this is a post-operative recurrent site here, which is having extensive infiltration with significant uptake. And this is a whole body of the same patient here, only local disease, rest of the body is absolutely normal. So with the help of PET, you can delineate how the lesion is involving. This area is not involved. So PET is very important in evaluation of the soft tissue components. Coming to elbow PNET, these are all the diagnosed cases actually which came to our department for staging, restaging, or for the post-therapy evaluation. So majority of cases what I am showing are the worked up cases, diagnosed cases, and proven cases histopathologically. So coming, this is a 11 years old girl with a left elbow gradual pain, and radiograph has no abnormality which is detected. So PET CT was advised showing low grade FDG uptake, and post PET CT biopsy shows PNET. So it is very ill defined area which is seen in this. So very unusual, or we can't make it out unless and until it is very subtle. And this is a plain CT. So that is one of the reason, if you give the contrast, IV contrast, the characterization of the soft tissue within the lesions will become better, and that adds to the diagnosis of the PET, because necrotic areas, neovascularizations, these are the things which you can see after giving IV contrast in the CT. This is another synovial sarcoma, posterior chest wall for staging, large locally aggressive disease. If you see this, there is a large lobulated mass with ill-defined necrotic areas involving the left lower chest wall and left upper abdominal wall, and it is coming out extruding like a cauliflower growth. But if you see the PET here, it is extensive uptake is seen except for the small necrotic areas which doesn't show any sort of an uptake, and there is associated with the lumbar vertebral uptake consistent with the metastasis, but rest of the lungs appears grossly normal, rest of the body is normal. So coming to this very unusual entity, it was like some sort of a, like the asymmetry between these two hands, which shows that there is some sort of fullness. And if you see this clinically, there is some sort of like a lesion or swelling or edema, subcutaneous thing. But unfortunately, it came for a PET for evaluation, and nothing specific was formed. And it was a case of subungual poroma. Subungual poroma is a non-malignant entity, and histopathologically it was diagnosed. And this is that a case where the focal area of the thenar muscles are involved in this, with a non-specific uptake which is still having a good SUV values. It was roughly around 5 SUV max. So even though it is not a malignant entity, but still this sort of lesions will cause confusion in the evaluation of a routine things. So always we should have a dictum of following the protocol to diagnose certain things, and if they are not, then the unusual things comes later. Coming to soft tissue sarcoma now. This is another case which is a soft tissue which is having patchy enhancement here. These are the vessels, so it is a post contrast study, and lot of necrosis is there. So necrosis doesn't go give any sort of an uptake, except for the uptake significantly which is seen in the solid viable tissue. So if you see this in the sagittal sections, it is a large lobulated cauliflower-like growth with heterogeneous enhancement and inhomogeneous uptake seen involving this. So rest of the body is absolutely normal. So this was for staging. This is very interesting case. It was like a diffuse extensive myositis patient. Extensive. You see this, there is a inflammation with linear collections involving all the muscles of the body. The reason was not known. Patient was having fever on and off, and patient was poor, not able to come to the hospital, and financial constraints, and the later stage it was referred to the hospital, and from the hospital it came to our tertiary center for evaluation. It was showing the multiple streaky collections. It's not only the infection or inflammation, it is purely the collections like some sort of an abscess, probably disseminated involving all the muscles of the body. So coming to another interesting applications which has grown, because already I showed you one case of the post-operative osteosarcoma with the metallic implants. So metallic implants, metals means first thing is it is contraindicated to MRI, unless and until they are the MR compatible devices which are being used. But recently, most of the new devices what are available are MR compatible, but unless and until we are sure, we cannot take a risk of doing the MR scan for evaluation of the joints. So here comes the role of PET. So prosthetic joint imaging, hip and knee are the most commonly replaced joints, and 5% of respective prostheses become infected, and serious complications with discomfort for patients, need of repeat surgery, potential loss of implant also can be the possibilities. So differential diagnosis, there are two things which you should always try to see and give the diagnosis based on this. First is prosthetic loosening. Second is infection, which makes discrimination difficult but imperative to ensure correct therapy. So indium 111 labeled leukocyte scintigraphy and sulfur colloid bone marrow scintigraphy are the gold standard. And FDG PET CT in hip prosthesis sensitivities and specificities are around 90%. And a meta-analysis from 2008 pooled sensitivity and specificity of 86% and 82% respectively. So these are certain things which were proposed for interpretation points for FDG uptake pattern in suspected hip prosthesis infections. And these are like acetabular component for infection, non-specific inflammation, femoral neck, femoral stem and tip of femoral stem. So coming to prosthesis imaging, this was a femoral prosthesis which was done. Patient joint replacement can be commonly accompanied by post-operative pain, but aseptic loosening or infection can be the cause of pain, and clinical challenge is to differentiate between these two causes of pain. So loosening is a different entity and infection is a different entity. Loosening can be there without infection, and infection means there is some sort of a activity, bacterial, viral activity going on. So if you see this, there is some sort of a activity along the joint replacement prosthesis which has been put in the femoral shaft. So it is along and along on both sides. So rest of the body is absolutely normal. So it is consistent with the post-operative infection. Coming to prosthesis, another, this is a knee joint here. Very difficult to comment on the CT images. That's why CT is sometimes useless. But if you see the PET here, there is some sort of focal mild activity seen around the knee joint here and in the suprapatellar region with focal uptake consistent. Retrospectively, carefully, if you see, there is a focal area of inflammation in the region of a knee joint. So coming to infected right hip prosthesis, you have again the focal area of uptake surrounding the neck of a femur, which shows no relevance in the CT images, which shows significant amount of artifacts here, and the PET is consistent with this. So infected knee prosthesis. So infected knee prosthesis is one entity where you have the focal area of bone erosion associated with destruction and the soft tissue thickening. So coming to facet joint hypertrophy, this is a hypertrophy which shows significant amount of uptake here, and this hypertrophy is showing the sclerosis. So there are different variations and lot of applications are coming. Now coming to this one entity, very interesting, this is a knee joint. These are the two different cases, two different patients which are, one is obese and another is non-obese. So obese patient will have an uptake because there is weight bearing, there is significant amount of weight and there is subtle patchy area of sclerosis which shows significant amount of uptake in the knee joint, and this is consistent with the amount of more uptake because of the more weight bearing, more activity compared to non-obese knee joint here where there is no significant activity. So this is one of the thing by which the knee joint is being evaluated, and on the same basis the osteoarthritis grading, staging are the things which can be easily diagnosed and distinguished by the PET in future. So coming to osteoporosis, this is significant bone osteoporosis, nothing, absolutely nothing. But if you see, other than osteopenia, there is no uptake, but only the focal area of facetal arthropathy or hypertrophy is there because of the weight bearing, probably in the lower lumbar region, that gives increased amount of uptake. So that is also one of the thing, because of the more continuous stress, movement, activity and weight bearing, this results in the increased amount of uptake. Otherwise, it doesn't have any significant relevance. So coming to degenerative disc disease and degenerative bony disease, there are extensive uptake again. So it can mimic some sort of a focal area of metastasis or multiple metastases. But again, This is significant extensive degenerative changes which will give the significant amount of activity in the entire spine. So, coming most common form of inflammatory arthritis is rheumatoid arthritis. It affects 1% of the population. It can be chronic autoimmune inflammation. Leukocyte infiltration is common. Proliferation of the synovial membrane. It results in destruction of bone and cartilage. And FDG accumulates in the activated leukocytes, inflammatory process, secondary changes of hyperemia or erosions, and bone scintigraphy and plain film radiography respectively. So, if you see this, the upper row, this is normal hand, and if you see the down, this is a rheumatoid arthritis hand, same thing. So, extensive, if you see the comparison here, wrist joint, there it is normal, but here abnormal, synovial thickening, soft tissue thickening, edema. So, there is significant amount of uptake in the wrist. Same applies to the interphalangeal joints, carpo metacarpal joints, interphalangeal joints. So, that is one of the promising area of application of the FDG PET in rheumatoid arthritis in coming years. This is PET MR in the rheumatoid arthritis, as MR is more sensitive for the soft tissue evolution. Even the minor synovial thickening or any sort of minimal soft tissue can be seen, and it correlates well with the PET. So, the blend of PET and PET MR is one of the most important aspect in this. So, coming to FDG PET, you have red marrow activity. It detects involvement, chronic anemia and myelofibrosis. So, increase hematopoiesis, reconversion of yellow to red marrow. So, you have myelofibrosis, hematopoietic stem cell neoplasm, bone marrow inflammation, reactive bone marrow fibrosis, extramedullary hematopoiesis, and the intensity of bone marrow, that is 18F FDG uptake, decreases as the bone marrow fibrosis increases, and bone marrow inflammation in myelofibrosis. So, coming to myelofibrosis, there is a literature which shows the diffuse amount of uptake in the bones here involving the long bones. So, fibrous dysplasia, it is a benign disorder. It is a fibrous tissue replacing bone. Fibrous dysplasia shows an increase in FDG uptake which can mimic malignant bone involvement in FDG PET. An FDG PET CT scanning on a patient with known fibrous dysplasia found an elevation in the uptake of FDG in numerous locations that were identified as FD. So, I will show you the mechanism in the coming slides. So, this is a physiological muscle uptake which you should remember in the anterior chest wall and the paraspinal regions. So, that should not be confused with the abnormal uptake. This is a physiological uptake, but due to the increased muscle activity. So, muscle activity is more. So, coming to focal cortical thickening with sclerosis. So, this is a focal area of cortical thickening which shows uptake in the lateral aspect, and this is consistent with the focal area. Rest of the bones, rest of the soft tissues are absolutely normal. This is a case of ivory vertebra here which does not show any significant uptake in the bone, but the cause of ivory vertebra is important here to identify how the uptake is seen. So, this is another entity of liposarcoma, fat component which is less uptake. So, this is a liposarcoma. So, fat does not show any amount of uptake within the lesion, but periphery of the lesion is showing the uptake here. So, it is consistent with the liposarcoma. It was a diagnosed case of liposarcoma. So, coming to tumor calcinosis, this is something very surprising. This is a calcified tumor calcinosis component, but still it will show a significant amount of uptake because of the activity within the tumor calcinosis cells. Now, malunited fracture neck of femur here. So, if you see this, there is malunited, but there is some significant activity along this with the significant malunited areas and cortical irregularity. So, it is consistent that the malunited area is because of some sort of a infective activity which is going on in the region, and that is one of the reason the union has not happened in a proper way and it has resulted in malunion. So, coming to multiple cutaneous lesions. So, you have musculoskeletal as well as cutaneous lesions. So, these are only seen only in the lower limbs here. see the skin, irregular nodular thickening is there, irregular nodular thickening is there, but rest of the proximal body is normal. This is a pelvic ileal system, excretion of the FDG contrast, and these are the uptake in the urinary bladder. So, if you see the lower limb, extensive multiple skeletal lesions are there, which were consistent with the infective inflammatory as well as melanoma. So, GCT, pathological fracture internal fixators. So, this case already I have shown you. Osteoporosis, nothing unless and until it is an active collapse, it will show an uptake, active collapse. Passive collapse, chronic collapse will not show the uptake. So, that is one of the aspect by which PET can give some sort of an infection. Diffuse marrow uptake in the body, diffuse increased marrow uptake, it can be reactive or it can be some sort of a post chemotherapy where the systemic medication has been given. Now, coming to the interesting case here, low backache associated with fever, low grade since 1 month. So, if you see this, there is some sort of a irregularity end plate changes at this level, and this is consistent with the uptake along the end plates, and this shows the SU max of 5, which is consistent with the spondyloarthritis. So, coming to history of trauma, no fracture, pain is persisting. So, PET-CT shows diffuse uptake in surrounding muscles. So, here there is focal area of uptake, bones are absolutely normal, but sometimes increased uptake is because of a sprain which cause some sort of a activity in that, and it is like some sort of a muscle uptake because of overactivity. And this is a 3D reconstruction in a different color coding here, which shows a fracture, and fracture margins show the significant activity. So, it is like a acute fracture or active fracture which shows some sort of a healing process in this, and that is the reason is showing an uptake. So, it was a diagnosed case. Now, coming to very simple, it is a CA breast with stage 4. So, obviously PET hip on and off, PET shows diffuse irregular uptake right femoral head. See this is deformed patchy sclerosis, irregularity and reduced joint space, and it is consistent with the significant amount of the uptake in the head, neck and intercondylar region and probably proximal shaft. But again high grade fever was there, severe pain, doubtful. So, histopathology advice turned out to be Cox right hip. So, always remember two concurrent pathologies can coexist. It does not mean that it is a diagnosed case of carcinoma breast. So, any sort of a lesion involving musculoskeletal system or any part of the body should be considered metastasis. So, you clinically you have to see it is a high grade fever, severe pain, and analysis has to be done very logically. This is a post-traumatic status X-ray, no fracture, fever on and off. So, this is like some sort of focal area of uptake which is seen here. And if you see carefully, it is a like suprapatellar effusion here, that is all. That is inflamed, that is probably infected. And this is severe back pain, no trauma, chronic. So, you have erosion of end plates, fever on and off, and this is a case of infective discitis. So, this is a reformatted image of the bone with superimposed PET images. So, coming to nocturnal pain on and off, all imaging normal, MRI normal. So, PET-CT shows some sort of a focal area of uptake which was consistent with the myositis, but the differential is normal physiological uptake is also there, but with the history of nocturnal pain on and off, so it does not match with either myositis or it is a not a normal physiological uptake. So, this sort of it can be an inflammatory myopathy, that is some sort of a different entity. So, diseases affecting the structure of bones like Paget's disease, osteoporosis, renal osteodystrophy, change in bone turnover, serial evaluation, and quantification of regional disease activity with the sodium fluoride PET may be useful to assess the bone. So, Paget's disease of the left pelvic bones. So, this is a significant uptake which shows. So, Paget's also will show a uptake. So, these are all the things which we should remember while evaluating PET with the various musculoskeletal pathologies, and there is a literature which shows the involvement and the role of PET-CT. Diffuse myositis, diffuse uptake, these are two different cases, extensive involvement on the left side. It is again the polymyositis and dermatomyositis. These are two different entities which can be shown, and again giving a false result because of the involvement of the skin as well as the muscles. This was a very interesting case, oval cystic lesion, left thigh, small enhancing nodule, features were suggestive of a hydrated cyst here. It is some sort of a nodular this thing here, which is cystic lesion, no significant uptake. And features, these were the axial sections, and this was a hydrated cyst which was involving the muscles. So there are so many things which will be involved in the many ways. So diabetic already I have shown. So DVT is again something not related with the musculoskeletal system, but again it can be a part and parcel of myositis or inflammation or some sort of subcutaneous edema or cellulitis involving the muscles. So again the whole body link is between thrombosis and inflammation. That is only the thing. An FDG for quantifying global disease activity, allowing for monitoring the disease course and response to the treatment. So if you see this case, this is like extensive thickening, nodularities, edema, and extending into the muscular planes here. So, and the contralateral limb is absolutely normal. Coming to another important radio tracer which I was focusing is 18F sodium fluoride PET CT. It is done for evaluation of skeletal metastasis and it is similar to bone scintigraphy. So bone viability of sodium fluoride PET, it measures bone blood flow, access the extent of viable bone in the femoral heads, setting of trauma or reconstructive surgery. One study demonstrated that a decrease in blood flow or decreased sodium fluoride influx predicted the eventual need for joint arthroplasty. So this is a F18 bone scan. It is a type of a bone scan done with the PET, not routine nuclear bone scan. So if you see this, there is patchy sclerosis here, but which is more on the left side, and the uptake is corresponding more on the left side, suggestive of bilateral condensi iliae. So you have F18 bone scan where multiple bone metastases are involved. So these are all the multiple bone, skeletal bone metastases, sternum and the multiple vertebral bodies, pelvic bones and the ribs. So it is consistent, and F18 has very important role, especially in the sclerotic metastasis where FDG is having a problem in evaluating the sclerotic metastasis where the FDG SU values are not very high. Again, this is extensive skeletal metastasis here. Coming to Dotanoc radio tracer, it is used for NET, HPE prostate NET. NET is neuroendocrine tumor. So bone metastasis uptake is like same FDG. So if you see this, there is erosion, destruction of the bone with the soft tissue infiltrating the muscle and the bone marrow. And this is a prostate which is infiltrating the urinary bladder. So it is a prostate primary with the skeletal metastasis, but this is done with the Dotanoc radio tracer, not with the other radio tracer. That is the same case here with the another which is the extensive skeletal metastasis. So coming to novel radio tracers which may play a role for examining specific pathologic states, among these are those to assess the bone marrow diseases due to variable pathologic states. So you have 18F fluorothymidine, a radiolabeled thymidine analog which reflects cellular proliferation, differentiating proliferative marrow, hematologic malignancies, leukemia and multiple myeloma. So this is some sort of a which already I have shown you in the before starting the showing the cases. This is the same thing. So you have high in benign, low in malignant lesions. Bone also same thing, high uptake in benign but low uptake in malignant lesions. So coming to the radio tracers here, already I have shown about FDG, sodium fluoride. You have PSMA for the metastasis of the prostate cancers. Choline is used for proliferative changes in arthritic synovium. So this is something which will be coming in future, very common to evaluate the synovium. This is for activated macrophages, and 18F FTC is 146 is for active neuropathic pain. So coming to last one or two slides, the role of PET MR, this is not a part of my talk, but just one case I just want to show how different it will be the scenario with the compared to PET CT. So it is a new hybrid imaging modality. It is more sensitive compared to CT and soft tissue lesions. So this is a case of multiple myeloma where PET is normal and MRI is abnormal. So if you see this PET is normal, but MRI shows extensive mixed density bony lesions here with erosions, end plate changes, subchondral bony changes. But fused PET MR doesn't show. So there are certain times where MRI will be more sensitive, more specific as compared to PET. But the blend of PET and MR imaging modality will be the best combination to be coming in future, and it will overcome the role of PET CT, especially in relation with all soft tissue components. Only the gray area will be for PET MR will be the bony evaluation. So with this, I hope I have covered all the things, and I am thankful to all of you for giving this kind attention. So there are couple of questions here. Where do you use technician 99 MDP bone scan? So technician 99 MDP bone scan is a routine nuclear medicine gamma camera bone scan. It is has the same indications, especially in relation with the metastasis or the skeletal whole body survey, but that is not as sensitive as that of the F18 bone scan or FDG or any other radiotracer PET scans. So the sensitivity of MDP is less, but it's done routinely because it is easily available and quite economical, quite cheap compared to the PET CT. Coming about another question, what about PET like MRI diffusion? Yeah, that is very interesting question because the MRI diffusion whole body concept has come with a significant combination that lot of literature is coming in future, lot of coming in future where you can see. So it is very important that in future the whole body diffusion with the invert grayscale, the images resemble that of MR of the PET. But the important advantage is of MR will be the no radiation. But still lot of things, lot of way has to be gone because the sensitivity and the evolution in the technology for the whole body diffusion is coming not to the level of PET, but probably down the line in couple of years definitely it will be equal to PET, and with the sensitivity equal to PET, the MR will be more preferred, diffusion MR will be more preferred because it is non-radiating and no radiation dose isotope or the CT radiation has to be done as in the case of PET CT. Why you use DOTA-NOC for prostate cancer? DOTA-NOC is not a ideal radio tracer for the contrast for the prostate. For prostate, it is a PSMA, that is prostate specific membrane antigen. So that is more sensitive. But if I showed you a case where the DOTA, it was a neuroendocrine tumor of prostate. So wherever neuroendocrine tumor is there, the radio tracer of choice is DOTA-NOC. So unfortunately, it was a neuroendocrine tumor of prostate, means we have to use DOTA-NOC rather than using PSMA. So PSMA is ideal for any prostatic cancer primary other than neuroendocrine tumors. Hope I have answered, and there are a couple of things which are of not much relevance. So any further questions? I think I have answered the important ones.
Yeah, I think you got to everything, Doctor.
Yeah.
Well, as we bring this to a close, I want to thank Dr. Sheikh for this lecture, and thanks to all of you for participating in our noon conference. A reminder that this conference is available on demand on MRIonline.com, in addition to all previous noon conferences. Be sure to join us Monday for a lecture from Dr. Rajdarkar on pediatric chest emergencies. You can register for that at MRIonline.com and follow us on social media at the MRI Online for updates and reminders on upcoming noon conferences. Thanks again and have a great day.
Thank you all.